Dear colleagues, good morning, good afternoon, wherever you are. We are really glad that you are able to join us to this important webinar. As you know, this is a joint effort with key partners, and NEST 360 and UNICEF has been co-creating this package. And today we will be having this learning webinar, interactive webinar for specifically focusing on the human resource. This toolkit, you'll find it in the indicated website, and also you can access and download and use this material. And these are the series of webinars, and this is the first for the 2013 for this year, and it focuses on the human resource for health, which is a key aspect, a key pillar, a key block to ensure timely quality care for small and sick newborn. Without human resource, we cannot achieve that goal. So the topic is small and sick newborn care. Which human resource do we need and how many? As I said, this is interactive session. So I will be your chair for this session, and we have 6 excellent speakers on this topic. Each one of them will share the titles as you see. The neonatal HR norms and gaps, the themes and the data that we need and what we have. We will hear also on pediatric and neonatal perspective, neonatal nurse perspective, midwife perspective. All these are the different human resource part of team that deliver this service. So we will hear their expertise. And last but not least, we will hear on the biomedical education and practice. And we have planned also to allocated a 15 minutes answer and question session for where we will attempt answering your question. In the meantime, you can use the chat box to write your comment, your answer. We will be monitoring those and get back to you. So we will start now with the first session, who will be by Dr. David. The floor is yours, David.
Thank you, Tedbabe, and great to have you all on this call. David Gathara, an assistant professor of health systems at the London School and part of the doctoral team leading the Small and Sick Newborn Toolkit content development. Next slide. So I will give a small introduction to the talk today, and then I will hand over to other speakers who will provide some bit of more detail on what's happening in other settings and with other professions. Next slide. So just to open the conversation today is this quote by Dr. Tedros at the International Council of Nurses Congress in 2019, where he said we can have the best medicines, the best diagnostics, the best hospitals, the best insurance, but if we don't have health workers delivering safe, effective, people-centered care, then we don't have a health system. And as we'll hear later from Rebecca on the data that we have, and other speakers, that this is probably the same situation that others LMIC settings are experiencing, but more so in the newborn setting. So LMICs have a gap of approximately 18 million health workers. 89% of the 5.9 million global shortage of nurses are within LMICs. And compared to high-income countries, on average, where you have 10.9 nurses and midwives to 1,000 per population, LMICs are, at 0.9 per 1,000, and that's a very glaring difference, and yet we expect to deliver the same levels of care. And WHO continues to advocate for strategies to improve human resources, especially in LMICs, and universal access to quality could prevent up to 1.7 million neonatal deaths per year and 68% of potential deaths by 2030, with 2 out of 3 small and sick newborns being managed in a level 2 special care units with higher level newborn units, and 70% of all preterm deaths could be avoided if by special newborn care alone. And currently, 75% of babies in Sub-Saharan Africa and Southeast Asia have no access to special newborn care, which is going to be the focus of this talk, but just speaking to where the investments should be going to. Next slide. And just reflecting on some of the guidance from WHO, this document that was recently launched on roadmap on human resources strategies to improve newborn care in LMICs. Strategy number 7 is very clear on ensuring effective staffing, staff ratios, skill mixes in local neonatal units. And here the area of focus is level 2 special small and sick newborn units, with the essential cadres being neonatal nurses or nurses or midwives with specialized competencies in newborn care, clinicians trained in neonatal care that could span pediatricians, neonatologists, medical officers or clinical officers, laboratory technicians, biomedical engineers, nutritionists, support staff and administrative staff, and some of whom are very critical for supporting care provision, but also supporting documentation of care and collection of data that will help us track progress. And there's a whole load of other multidisciplinary teams, including surgeons, speech therapists, ophthalmologists, lactation consultants, that are necessary to comprehensively give specialized care that may be needed for small and sick newborns. So the takeaway message is that we need the right cadres for health workers with the right staffing ratios and skills mix. Next slide. So when we think about how many of each cadre do we need, is the guidance from the American Council of Obstetrics and Gynecologists that provide the staffing ratios for nurses to be 1 nurse to 2 to 3 patients in special newborn care units. And we can see similar recommendations for LMIC settings from work done based on review of data in India and South Africa and consensus building work in Kenya. And additional staffing that are required in this setup is at least a pediatrician on call, a medical officer who can give a 24-hour cover, nurses trained on neonatal skills or specialists in neonatal nursing. And then critically is the biomedical engineers or technicians that could be either hosted at a facility or shared across a set of facilities. And at higher facilities, then we need more specialized care as cadres as described in the previous slide. But what is clear is that we don't have very definitive standards for staffing ratios in LMICs. And as you can see, some of the recommendations are pretty much not very close to what we can achieve. Next slide. And what do we need? Then we certainly need to strengthen the human resources planning and policy regulations. This includes working towards optimal staffing ratios, produces adequately qualified skilled workers, strengthening the leadership and capacity at the Ministry of Health and professional associations to advocate for better staffing. But more importantly is to think about the investment cases for small and sick newborn and how to explicitly cost human resources and what standards to work with. And this is just work illustrating that, when we don't have enough staffing, where what is on the y-axis is how much care a nurse is able to deliver, x-axis is number of patients a nurse is looking after, and you can see as the number of patients increases, the amount of care that is delivered decreases, and therefore a critical thing that we need to flag, that we probably are not doing what we should be doing in terms of care provision if we don't have enough hands on the ground. I'll now hand you over to Rebecca to share additional data from NEST 360. Rebecca.
Thanks, David. So my name is Rebecca Penzias, and I'm a research assistant and part-time PhD student at the London School working with the NEST 360 program. Next slide. So I'm going to present some data from the NEST 360 program, which is being implemented in 68 neonatal units in 64 hospitals across Malawi, Kenya, Tanzania, and Nigeria. And most of the hospitals that we're working in are national or regional referral hospitals, though we are working in quite a number of district hospitals in Malawi. So today we have some data from two different NEST 360 data sets. So we have the health facility assessment data, which was collected at baseline before NEST 360 implementation. And this focuses on a lot of service readiness data across the health system, but we do have a lot of detailed staffing data in the health facility assessment. And then we also have a data set. We have these quarterly quality improvement visits in partnership with the ministries of health in each of the countries we work in, are visiting facilities on a quarterly basis. And though the focus is really on quality improvement for those visits, we do have some staffing data from those visits. Next slide. So first, I'm going to take you through some data on the clinical staff, and then later on, we'll show some data on the biomed technicians and engineers. Next slide. So I'm going to start by going through some data on coverage of doctors. And just to note that we did collect data on students and interns who are providing care on the neonatal unit, but all the numbers here are excluding students. So first, looking at 24-hour, 7-day-a-week coverage by doctors, we have this data from the HFA visits and also from the QI visits. So we can see in this first row here that at HFA baseline, there are actually very few facilities that had doctors physically present and providing care on the neonatal unit, both the day of the HFA visit and the night before the HFA visit. So we can see under all sites, only about 30% of sites met these criteria for 24/7 coverage. Then looking below at the last row, on the most recent quality improvement visit at the end of 2022, we actually see much higher coverage across these sites. So we're seeing about 90% of facilities having 24/7 coverage by a doctor. Then looking at pediatricians and neonatologists. So if we look at the HFA data, again, unfortunately, we don't have this data from the QI visit, but from the HFA data, we can see that around half of facilities or neonatal units employed at least one pediatrician or neonatologist, but only about a third of facilities had neonatologists and pediatricians, at least one, providing exclusive care on the newborn unit. So we can see here that there's a really clear need for more pediatricians and neonatologists combined with other cadres to provide small and sick newborn care. Next slide. So we can see that more doctors are definitely needed, but how many doctors do we need? And as David noted, looking at the standards, there aren't any standard staffing ratios for newborn units in low and middle income countries. So looking at the data here, we can see actually from the HFA and the QI data that there's a really wide range in ratios of number of babies per doctor at different facilities. And looking at the baseline data, we can see that there are actually quite a number of facilities that had 0 doctors, particularly in Malawi and Kenya. And then again, looking at both sort of data sets, we can see that there are higher staffing ratios at night. So there are generally fewer doctors around at night to provide the same care to the same number of babies. Next slide. So we've looked at doctors, and now we'll look at some data on nursing staffing ratios. So here we're showing the percent of neonatal units that have achieved a sort of defined threshold of nurse to baby ratios. And as David noted, some of the literature or the standards suggest a 1-to-3 ratio for this level of care, but we've used a slightly more conservative threshold of 1-to-4 as optimal care, and then greater than 15 babies per nurse as sort of least optimal care based on some other literature. And you can see here, both at the HFA and the QI visits, that actually very few facilities are meeting these optimal nurse to baby ratios. Next slide. So looking a bit more closely at the nurse to baby ratios, we can see quite similar trends actually between the doctor to baby ratios and the nurse to baby ratios. So we see again here in both data sets that there's a very wide spread of ratios between facilities and between different countries as well. And we can also see again that nurses are caring for more babies at night compared to during the day, which is the same case that we saw in the doctor to baby ratios. Next slide. So now we'll look at some biomed staffing data. Next slide, please. And as David noted, speaking about the standards, facilities should have 1 to 2 dedicated biomeds at least per facility, with engineers supporting a larger number of facilities. And just to present this data a bit conservatively, we've combined those categories. And we just have this data from the baseline HFAs. So at baseline, most facilities had at least 1 biomed or engineer in Nigeria, Tanzania, and Kenya, but we're still seeing, even at baseline, a lot of major gaps in employing biomeds and engineers in Malawi. And then looking at the second piece of data, only about 2/3 of facilities had biomed techs or engineers exclusively assigned to that facility. So we can see here that there's some major gaps in having dedicated biomeds and also employing biomeds to support small and sick newborn care. Next slide. So looking at all this data, what can we really take away from the data? So first, looking at staffing ratios, though there aren't any defined standards for staffing ratios for newborn units in low and middle income countries, we can see that the doctor to baby and nurse to baby ratios are quite high, both during the day and at night. And then we can also see, looking at the doctor to baby and nurse to baby ratios, that all clinical staff are really caring for more babies at night because of gaps in coverage. Then thinking about specialist care, so only about half of the facilities that we looked at in NEST even employed pediatricians or neonatologists. So we can see that there are definite gaps there in availability of specialist doctors to provide care. And then lastly, looking at the biomeds. So it's really important for biomeds to be exclusively assigned to facilities to support timely maintenance of devices and technologies needed for small and sick newborn care. And only about 2/3 of the NEST facilities had this. So this data really suggests that overall there's a need for more trained staff, including clinical staff and biomeds, in order to provide high quality small and sick newborn care. Now I'll pass to Dr. Olufunke Bolaji to talk about the pediatric and neonatal perspective.
Thank you very much, Rebecca. So my name is Dr. Olufunke Bolaji. I'm consultant pediatrician at the Federal Teaching Hospital in Ado-Ekiti in Nigeria. I'm also the chair of the Collaboration and Advocacy Committee of the African Neonatal Association. Next slide, please. So taking off from where Rebecca left, we definitely see that we have a need for specialists, neonatologists, pediatricians, doctors, surgeons who can provide effective coverage. And when we say effective coverage, we actually mean that the access to care by the population and the quality of care. We've noted that the higher the number of babies that either the doctors or the nurses are seeing, then the quality of care that is provided is less. Next slide, please. Next slide. So I want to talk about the role of specialist training for newborn care. We've noted that as the complexity of care increases, therefore the need for specialized healthcare workers with specialized skills and additional competencies are needed. For neonatal nurses, we still have a session for the nurse perspective. We've noted that neonatal nursing is not a widely recognized cadre in low and middle income countries, and very few countries actually have formalized training. In fact, you're more likely to find this category of general nurses in many countries. Cited example of South Africa, but in many countries in sub-Saharan Africa and the low and middle income countries, we'll just find generalized nursing, and that's not supposed to be so. So it would be nice if we could have this cadre of highly skilled healthcare workers that are defined through national policies, and that they also define what is the scope of practice and their regulation in their integration into the general cadre for civil service registration and structure. It's also good to have that their curriculum of training is tailored along the 3 levels of care for expertise at these levels, including newborn stabilization and safe transfer. Next slide, please. So there are a few countries who have done this specialized training really well. Ethiopia was able to introduce a compulsory service commitment to the neonatal unit after a 4-week off-site neonatal nursing course, such that after the participants go for this course, they are dedicated to working in the neonatal unit because of the investment that the country has put in them. Morocco too also had this specialized cadre of healthcare workers where immediately after secondary school, they could go for this bachelor level training, and their curriculum is tailored towards neonatal resuscitation, towards internship in neonatal acute care, and they even needed to present a thesis. So if there are countries like this that have done it, there are other countries that could also emulate it so that we have healthcare workers that are tailored with specialization towards neonatal care. Next slide, please. Next slide, please. So for the specialized training that we need in low and in middle income countries, we've reasoned that the leading causes of death would actually guide what specialized training we need in low and middle income countries. The leading causes of death are still prematurity, asphyxia, and infection. So the next slide will show that we actually need capacity building. Next slide, please. We need capacity building in neonatal resuscitation. We need capacity building for KMC and IKMC. We need capacity building for infection control. These are the 3 leading causes of neonatal deaths in low and middle income countries. And in addition to that, we also need specialized people who are specialized in data management and people who are specialized in building perinatal networks, because if we all network together, the human resources network together, then we can actually have better outcomes for newborn care. Next slide. So before I leave, I want to take a bit on the effects of epidemics and humanitarian situations on the human resources for many of the countries in Africa. The COVID-19 pandemic taught us that the health systems could really be overburdened really quickly. So even though newborns are less likely to die from COVID-19, their service delivery will be interrupted because of the overburdened health systems. So before emergencies happen, we should ensure that we have involvement of all key health professional groups at the level of policies. We should adopt and implement policies that will take care of international recruitment and migration of healthcare workers. Part of the problems that could ensue with health resources, with human resources, is the migration of healthcare workers. We've talked about specialist training, that there is really a dearth of specialist training in Africa, but migration of healthcare workers is also an important thing so that we can optimize retention. We also need to plan for the legal requirements on human resources that will be required during emergencies. And we need to support creation and strengthening of local and national professional organizations, foster the IPA, and the key messages I wanted to take away from here. Next slide. Next slide, please. The key messages are that investment in neonatal health really is an investment in human capital. We need to put our investment even as far into the global and national policies. Our investment will require more education, continued education programs for doctors and nurses. There are very few places in Africa where we can actually have specialized neonatology training, and this we can definitely improve on. And then when it comes to issues of international relevance, like healthcare worker migration, recognition of qualifications when we are moving to different countries, specific issues when there are humanitarian and fragile settings, all this should be addressed by global policies. Thank you very much for your attention. I'll take it. The next speaker will now be Sue, who will be talking on the neonatal nurse perspective. Thank you.
Next slide. Thank you, Dr. Olufunke. My name is Sue Prulage. I am going to speak for the Council of International Neonatal Nurses today, and I am the Director of Nursing for COIN. Next slide, please. So next slide, please. We don't need that. So COIN, which is the Council of International Neonatal Nurses, was incorporated in 2005. We represent over 60 countries. We have 17 national organizations from Australia to Rwanda. And we have people working with us in Hawaii and Zambia. And we consider ourselves the voice for neonatal nursing globally. Next slide, please. During our work, we've been asked to consult on many, many things. I'm going to mention 4 here. We helped develop curricula and teach in Rwanda at the Masters of Neonatal Health, their program. And we work with the Ghana College of Nursing and Midwifery. We're doing a couple projects there that around education of faculty and the cadre. The East Central South African Council of International of Nursing, we developed a postgraduate neonatal course for them. They're getting ready to start that program soon. And we've taught in the neonatal nurse practitioner and mentored students in the Zambia program. Next slide, please. And in all of our consulting, we've identified 7 gaps that run across all of these programs. There's no standardization of neonatal content across curricula, and I think that's been mentioned. There's a lack of neonatal trained faculty, a need for clinical faculty preceptors, a need for clinical nurse educators, a lack of trained staff with neonatal units, lack of recognition of the specialization that was mentioned before, lack of sufficient nurses to care for the small and sick. Definitely, we've seen that. Next slide, please. So I'm not going to talk about all 7 gaps, but let's talk about the lack of neonatal staff. Now, studies have shown, many studies have shown, even across Africa and all over, that if you don't have enough staff to take care of the small and sick newborn, that it directly affects the survival of those newborns. Renshaw and Tarlow did a study that showed that if you had a qualified neonatal nurse, not that she had to take a specialized course, but if she was qualified by some standard, that when she was on duty, it directly affected neonatal mortality. Deborah Woods and Stegman studied qualified nurses and showed that when you had inexperienced nurses taking care of the small and sick newborn, that you had more medical and clinical errors, and this affected the babies. And when you have insufficient staff, then you have missed care. And whenever you have missed care, babies are harmed. Next slide, please. So the lack of recognition of the neonatal nurse is important. I was just in Africa and had a discussion with a director of nursing that said, well, those generalized nurses are not neonatal nurses. And COIN has a position statement that anybody that works with the small and sick newborn is essentially working in a specialized unit and deserves the care that they need to have. So, and she believed that she could move she believed that the generalized nurses needed to be moved every 6 months to have their skills improved. So every 6 months, a new influx of unexperienced nurses would enter the neonatal unit. And when you have inexperienced nurses taking care of the small and sick, the neonatal mortality goes up. So I would advocate that they have an orientation and some education. We would advocate that they would have education and orientation before they touch the small and sick, and that would be recognized. And then they slowly develop their competencies and their skills as they work. It takes at least a year for a nurse in a neonatal unit to develop the skills and competencies to be just a little bit better than a novice nurse. So, studies have shown when you have that specialized nurse that's had the training, that it improves patient outcomes and you have less failure to rescue events, and patients are safer and you have less medication errors. Next slide, please. So why do we need those nurses? Neonates are different. They're the only patient in the hospital that are 100% dependent on the nurses and caregivers for everything that they need. So that's different than any other patient. And so we need enough staff to take care of them when they're there. If you don't have enough nurses, then you have increased missed care events such as IVs not checked. Nurses are rushing around, touching babies without washing their hands, and it shows that infection rates go up. Interesting, in the United States, when the staffing was greater than 1.4, they had 24% increase in their missed care events. So if we're doing 1 to 15, 1 to 30, we're doing a lot of chances of miscare for sure. Medical incidents go up when you don't have enough staff. Morbidity and mortality, of course, goes up. Infection goes up because they don't have time to wash their hands in between babies. And one study showed that the retinopathy of prematurity and the bronchopulmonary dysplasia definitely goes up because they don't have time to attend to the oxygen saturation changes that happen with the small and sick newborn. Next slide, please. So how do we document that? We've had a lot of discussion. COIN has put together a group of people that are looking at this. Dr. David's on it and Dr. Joy's on it. The African Neonatal Association has come on this team. Vaughn is on this team. Nest is on the team. And we're looking at what we call nursing indicators. Exactly what do nurses do during the day? And how do we quantify that to make that work with nursing or the nursing acuity, instead of having just say, okay, we're going to work with 5 nurses today, no matter what. You look at acuity, and then based on the acuity going on in the unit, you staff accordingly. So some of the indicators that we've discussed already is patients on the ventilator, patients on CPAP, IVs, how many times are they going to have to start IVs, medications, nasal gastric tubes, how many times during a shift did a baby have to be resuscitated. These are all nursing indicators. Next slide, please. So how do we correlate those indicators with acuity? I had to go out and look for the definition of acuity, and there's 3 possibilities here, because we'll have to define what we mean by acuity if we're going to develop a tool. The first one is the possibilities of classifying the time and dedication of the nursing acts so that you can affect human resources for the next shift based on that greater acuity. That was Siscal in 2023. Now, A1 says it's the dose of nursing care required for safe and effective care. The ANA describes it as a measurement of severity and complexity of an illness or the resources required to treat an illness. I like number 1 and 3. It's more easily to define than the dose of nursing care. So as we look forward to how to attend to the workforce, we need to look at nursing indicators and acuity tools. Next slide, please. So I went out and I found a really excellent tool. I'm just going to mention it here today, that it's by Roth. It was just published in 2023, and her associates. She developed a nursing tool that looked at 16 indicators, and it was based on a score from 0 to 4. 0 meaning that was the least amount of care that the nurse had to give to the baby, with 4 being the most amount of care that she had to give to you had to give to the baby. And it was very specific. For example, under respiratory, you had a score of 0, but as soon as you went on oxygen, you started the score of 2. And then it went up from there. So if you were on, for example, on a hood or on nasal cannula less than 2 liters, if you were stable on CPAP, you got a 2. And it went up from there. So 3 was just going on CPAP, a stable ventilator. And number 4 was like unstable ventilator, chest tube, that type of things. And it's very specific, and it's a very nice tool. And I think that a team of people, and there's enough people in this group that would be very interested at maybe looking and creating a tool so that we have an acuity tool that's based on similar nursing indicators. So then once we develop the tool, then we would pilot it And then once we have the pilot, then we could share it with the powers to be, such as the Ministry of Health, who is responsible for hiring nurses for these neonatal units. But we also need to share it with the nursing administration to show that the general nurses are involved in neonatal care also, that they don't have to have a degree to be considered specialized and stay within a unit, that we should consider everybody that touches babies as a specialization. And I think that is my way forward. I'm going to turn over to Bartholomew from the International Council of Midwifery. Thank you very much.
Next slide. Thank you, Sue. So I'm going to talk about the role of the midwife in small and sick newborn care, the best practice for midwifery care of the newborn. As already introduced, I'm Bartholomew Kamler, and I'm representing the International Confederation of Midwives. Next slide. So what is the case for midwives when we talk about human resources for health? In 2021, we had the state of the world's midwifery, that there's a global shortage of midwives around the world, and I think David touched on that as well. So in particular for midwives, we have a shortage of about 900,000 midwives, which represents a third of the required global midwifery workforce. And why is this important? It's because fully resourcing midwifery delivered care by 2035 could avert 65% of maternal deaths, but more so of interest, it could avert 64% of newborn deaths and 65% of stillbirths. This could lead to a lot of lives saved along the way. And midwives in particular can provide more than 90% of the reproductive health care once they are fully trained and specialized. Next slide. So it has been mentioned by WHO that the role of the midwife extends beyond neonatal care because midwives are able to also meet the physiological and psychological needs of the mother and the newborn. And we know that care that is given in pairs to the mothers and babies has got the greatest impact. Next slide. So in moving forward, I'm going to talk about 4 key aspects which have been highlighted by previous speakers on how midwives can support and care for newborns. And we're going to look at skilled midwives. We're also going to look at infrastructure and equipment, as well as retention and recognition, which Sue has already talked about, as well as the role of trained faculty, which has been highlighted as well in the previous presentation. Next slide. So midwives are the frontline workers in most countries, developing especially, and we know that midwives are the primary caregiver when it comes to mother-baby pairs. The midwife is responsible for providing respectful maternity care, preconception, during labor and delivery, and as well as postnatally. So when we talk about skills, we know in cases of an emergency or the need to provide basic neonatal competencies, such as neonatal resuscitation, which has been highlighted, this midwife who is attending to this pregnant woman needs to have the necessary competencies in neonatal care so as to be able to provide high impact care which can save lives. So the quality of care being received by the neonate has a bearing on perinatal outcomes. And so we need to ensure that the midwives who are attending to these pregnant women have the necessary neonatal competencies. Next slide. So it's not enough to provide midwives with the necessary skills and competencies. We need the equipment and the infrastructure to be put in place so that the mothers, the patients who are being given this care are attended to appropriately. Basic equipment such as resuscitator in most countries may not be readily available, especially in far-flung places which may not have access to power. So in such cases, it may be difficult to provide the basic neonatal care that is needed. And so we need to put in place measures to ensure that basic equipment for neonatal care is made available, such as resuscitators and also CPAP machines, which may be needed in places especially in low and middle income countries. Next slide. So retention and recognition has been highlighted, and I like what Stu mentioned. There's need to retain the staff that have been given the necessary neonatal competencies in the units where they are stationed. It's not good to be moving the midwives or then the staff that have been given neonatal competencies. Every 6 months you rotate them and you bring in a new breed of cadets. So we need to ensure that the staff that have been given the responsibility to care for neonates, they are supported and their hands are held as they're implementing this care, because it takes a while to give these skills to the midwives and the staff who are taking care of sick and newborns. And so they need to be supported, to be retained in units where this care is given, and also to be recognized for the care that they are giving. Next slide. Finally, the role of a trained faculty cannot be overemphasized. It has been mentioned that we need people who are able to give training to the next generation of staff among nurses and midwives, and we need trained faculty who will be able to support this cadre who is coming up, and to give them the necessary competencies in the clinical area, to give them the knowledge and skills in the classroom. So we need a faculty that will be able to pass on the knowledge and skills, especially when it comes to neonatal care competencies. Next slide. So in summary, for midwives to work effectively, they must be skilled, and an investment is needed in equipment and infrastructure, faculty recognition, and retention. And of key to note, in this particular instance, I happened to be trained by Sue about 3 years ago at the neonatal conference. And from the time I got those neonatal competencies, it has changed the way I look at small and sick newborns. And I really wish a lot of upcoming midwives, a lot of existing midwives who are providing care in these units are able to get those competencies to save lives. Thank you. And now I'm going to pass on to Dr. June to continue the presentation on biomedical education and practice perspective.
Thank you, but next slide, please. Can you hear me? Yes, thank you. I'm June Madete. I'm a senior lecturer at Kenyatta University School of Engineering. I specialize in biomedical engineering, and I'd like to talk about how we are supporting our biomedical engineers to enter the market. Next slide, please. So what is a biomedical engineer? I like these memes. I don't know if any of you have seen them. What my friends think I do, what my family thinks I do, and etc. What I do, I actually do. So who is it? WHO lists biomedical engineering profession as key players in developing and advancing the usage of medical devices and clinical services. Depending on their training, the sector of employment, the responsibilities of a biomedical engineer / technician profession can include from a deep one of overseeing the research and development, design, safety, and effectiveness of medical devices and systems, selection and procurement of the equipment that is coming into the unit, medical device systems, installation of medical devices, integration and electronic methods, records as well of the systems. Daily operations and monitoring, which I think is very important if we're going to, most of these technologies are used next to the baby. Managing maintenance and repairs, training for safe use and upgrading of medical devices available to healthcare stakeholders. Biomedical engineering professions are employed widely toward the health technology and healthcare industries in the research and development area. So in delivery of healthcare in hospitals and other institutions, it's very important that this training, both pre-service and in-service, is well structured and regulated. Next slide, please. So we have a very good website where it has data indicators of number of biomedical engineers in the world. And if you can see the image there, You have areas where there's no data, data not applicable, and so you can see there's a place where you have almost 600,000 biomedical engineers, but you have an area where it has 0. So if you look there, we have none of Africa has any dark areas. Next slide, please. If we just look at biomedical technician density per 10,000 population, and in the website, you can look at this data in different categories if you're interested. You can see we're very gray as well in our countries where there either is no data and we're not meeting the average. This reflects a serious shortage of biomedical profession in Kenya or in Africa, as also reflected in 20.
I think we have lost June. June, can you hear us? Can you hear me? Can you start talking? Yes, I think let's go to the addressing your questions. I think we have lost June.
Yes.
Yeah.
I'm back. Apologies for that.
Okay. Okay. Yeah. Go ahead. Yeah.
Sorry, I think I didn't even realize when I dropped. So I was just talking about. So just looking at this, we realize there's a serious shortage of what is required for a hospital, a country, leave alone a newborn unit. So it is estimated a total demand of 5,000 biomedical engineers exists from level 2 to level 6 health facilities, with requirements of 6 biomeds at each level 4 health facility and at least 11 for each level 6 health facility. So there is a shortage, and that is a case study with numbers in Kenya. And so this biomedical engineer, how do we support and increase the capacity, and also for those already in service? Next slide. We have a problem, especially when it comes to education. Biomedical engineering is very multidisciplinary. You can see there that you can go into industry, you can go into healthcare providers, you can go into government, all the institutional foundations that are there. You can have different operational, different innovations, etc. So there's a lot of synthesis, and this information comes from the WHO Medical Device Technical Series, and this is about to ensure improved access, quality, and medical devices. So what are we doing in the neonatal space? Next slide, please. Technology keeps changing. The need for continuous professional training is something we're looking into. At the moment, there's no structure like we have in other cadres, and this is what we're trying to actually emphasize from the association and to the ministry. On-job training is encouraged, and this is not structured, so it's a matter of how do we structure that. Extra training based on gaps identified is very important. And when I say also those extra gaps, if we had a biomed who was in service and then they were moved to another unit, how do we build capacity of those already in there? We also have come from all the information we've gathered over the last few years is the user interaction with the biomed is very essential to make sure the PPM is carried out, the maintenance is carried out, the monitoring is carried out, and this way we are going to save our babies. Support from management. So for example, what I mean by this is, am I in the procurement committee? If I need spares, will the machine stay in my workshop or will I get spares? If I want to go for training, will there be a replacement? Will there be facilitation for me to go for that training? So this is also encouraged. Inclusion of a biomed and procurement equipment as well. Next slide, please. So this all looking at all this, looking at what Rebecca said, listening to other cadres of especially what Sush said and what Doc said and Bart said, For biomed, I'm very passionate about it. Pre-service institutions are not well furnished to support training like other cadres, skills lab, for example, or capacity of staff to train. And that is like technical colleges, universities, etc. Large classes are normally very common in pre-service, and that way it's very hard to allow adequate training. How can we change this? Consistent in-service CPD trainings are not available, and this is also very important. The number of BME in the field are not enough for the population. So that's just a snippet of in Kenya has 0.04 biomedical engineers per 10,000 population. Senegal has 0.015, German has 0.2, with 25 universities having BME. So for pre-service, we need to be able to increase our training, and we need to be able to understand the path and the steps that every biomed needs to, from helping with the users, helping with the other biomeds, and in country as well. Thank you very much.
Thank you so much, colleagues, for this really excellent and enlightening presentation. The chat box and the question box has been also active. Thank you, panelists. You have responded to most of the questions, I would say. Maybe there is one question from, I think, that remain to be answered. I'm trying to see. Mita, can you help me which is remaining unanswered question?
There's a question from Desiree Habinol Mana. She wants to know, it concerns the first two speakers who briefed us on HRH shortages and LMICs. Her question is, how do you find it accurate to estimate HRH needs shortages based on the provider population ratio approach? There is an evolving interest to look rather at workloads when we estimate HRH needs, and there are tools in development for that measurement. I know it's not easy to use these approaches, but probably good to mention expected levels of workloads or amount of work these are expected in each facility.
Thank you, Mita. I also another question from Sriyahi. Is it equally important to have a continuous monitoring tool to ensure quality of service? You have not addressed it, but I think any of the panelists can come in. So let's address these two questions before taking two more. Any of the panelists, starting from David, if you could address. I'm not hearing if anyone is speaking.
David, are you able to speak, or maybe somebody else can take it? I can start if that's all right, and then maybe yes. I don't know if Olufunke. Yes, thank you, everybody. Really rich question. Thank you, Desiree. And I think it is important to look at case mix and workload. However, the advantage of at least having a threshold ratio means that you can move forward. If you can set a minimum threshold ratio for a level 2 small and sick newborn care that should be doing CPAP in order to meet the Sustainable Development Goal we all want to see, probably you're going to need, 4:1 or less, possibly 2:1, even if you've got a lot of babies on CPAP. So if we just leave it with no threshold, you end up with 80:1, as we saw here. So I think you need both. I think you need to set a minimum threshold, and then particularly as you move towards level 3 or more complex care, which Olufunke was talking about with surgery and so on, you may need to revise that. I don't know if that's helpful, and I don't know if anybody else wants to add to that.
Yeah, thanks, Joy. And yeah, just to echo your comment, Joy, and Sue's comment on reflecting on the need to take into account patient equity in in the staffing ratios, but also reflecting on the challenges of most governments where they, limited financing resources to actually get more nurses and more workforce into the system. I think it's also us trying to create optimal ratios that we can work with and say, here is a minimum, bare minimum that, all units should be able to achieve this, and countries should work towards that, but also give people a roadmap towards achieving that, because, moving from a ratio of 1:30 to 1:3 or 1:6 means employing 5-10 nurses per unit, which sometimes can be a struggle, but countries might be able to employ 2 additional nurses every year, which gets them closer to that ratio. And I think governments might find that more workable than, demanding 10 nurses at a go. So I think that's also a conversation we should have.
Thank you, David. Exactly. Those are, I think, critical points. If there are no more questions, I think the comments are also really useful comments from Joy, from Nina, from others on the training packages, upcoming trainings, and also in general on the topic we have been discussing. So I think we have had a really useful presentation. It's very sobering. The human resource for health question is not easy, because if it has been easy, it would have been solved by now. Through lack of investment in the human resource with adequate fiscal space, that compounded with ongoing brain drain to higher income countries, the low income countries are faced with deeply rooted shortage of human resource. So this is the reality, but through a lot of work within advocacy and also governments really coming up, stepping up and trying to address their weak health system, there are some hopes. We have seen from the 4 countries some changes occurring, but the key would be sustaining those and also doing those at scale. So we have heard from our panelists the need to have a team of healthcare workforce that is trained, supervised, supported, and have a functioning equipment. And for this to have, it's not only one cadre, but a team of health workers are needed. The second important factor we have heard is having the state or setting the standard and norms. If we don't have that, as we have heard in the presentation, and also from Joyce's comment, we will continue having one nurse caring for 80 patients, caring in quotation. So to change that, there needs to be at least the standard. And as David said, lastly, countries can take the step that is available, given the resource, the fiscal space they have to address this huge gap. Training for specialized nurses is needed. Maybe in the shorter term, I will call, maybe the immediate action could be if we avoid this short-term rotation, both within the delivery room and the small and sick newborn units, that even can address some of the immediate problems of having continuously new, less experienced, less skilled nurses caring for these vulnerable children. And I think that again emphasized, all the panelists have emphasized having the team of health workers. And for this to happen, if you have seen, each of them have called on increased investment for the human resource. Maybe, to highlight one quote, investment in neonatal health is investment in human capital. So for this is, key for economists. This is key for the Ministry of Finance, who are holding the pen in making the budget. I think we need to continue making that case. So addressing, the human resource again, is not a short term, but it is a work in progress, and the global strategies, global norms, standards, and continued advocacy are needed. And my last point is not only the clinical stuff, but the biomed, which has becoming, now recognized by many of the low-income countries is key. Some countries are trying to address that gap, but this requires, again, recognizing the need, making the investment, investing in the pre-service training to make sure that those cadres are trained and skilled. And importantly, they need to be integrated and incorporated within the clinical staff that are providing care in the small and sick newborn. So this brings us into the summary of our conversation. I think we are right on time, only 1 minute ahead. Thank you for joining us and attending. As I said, these are a series of presentation seminars, so look out for upcoming seminars, be engaged, and thank you. Have a good day.
Thank you.
Thank you.
Thank you, everybody.
Yeah.
Thank you.
Wonderful work. Really well done, everybody.
Thank you.